My name's Dr. Andy Lee, and I'm the neuro-ophthalmologist here at the Houston Methodist Hospital. Today we're going to be talking about 5 visual field rules that will help you avoid missing the brain tumor. And in order to apply these rules, we really need to know a little bit about the anatomy of how the visual pathway works. So here's the eyeballs, the optic nerve, the crossing point, which is called the chiasm, the tract, and then to the lateral geniculate body, and then the radiations which travel in the temporal lobe and in the parietal lobe to finally reach the back of the brain, which is the occipital lobe, which is where the visual processing occurs. And so the very first rule you need to know is that any respect of the vertical meridian in the visual field is a sign that it might be a compressive lesion from the brain tumor. And by vertical meridian, I mean the field as the patient is looking at it. So as the patient's looking at this, right eye, left eye, if the field is respecting the vertical, what it means is half down the middle is black. And so regardless of where the vertical step is, the vertical meridian is what is going to be the major rule driving the decision making on whether you should image this person or not. And so as you know, the optic nerve receives the light in each eye. It travels down the optic nerve, and then each of the nasal fibers crosses to the contralateral side, and that crossing point is called the chiasm. So as the fibers are getting closer and closer to the optic nerve, they're trying to split. The nasal fiber is trying to cross, and the temporal fiber is trying to stay uncrossed. And so you can get one-eye visual field defects from right here at this location, and that's called the junction of the optic nerve and chiasm. And so at the junction of the optic nerve and chiasm, you can get a one-eye temporal or nasal hemianopic field defect, and that thing is called the junctional scotoma of trochlear when it's a one-eye visual field defect that is respecting the vertical meridian. However, if it's involving the crossing nasal fiber as well, that thing is also a junctional visual field defect, but that thing's just called the junctional scotoma. And it looks like this. You have an ipsilateral optic neuropathy in one eye, plus a contralateral superior temporal field defect in the fellow eye. And again, the vertical step is the thing that is putting the lesion right here at number 1. At the level of the optic chiasm, it's still the same rule, respecting the vertical meridian, but because it's involving the crossing nasal fiber, that causes a field defect bitemporal, so it's in the temporal portion of your visual field. That bitemporal hemianopsia is a chiasmal lesion, and that's almost always a suprasellar mass, like a pituitary adenoma, craniopharyngioma, meningioma, etc. If you're behind the optic chiasm, that thing is called the optic tract. And any lesion behind the optic tract will produce a homonymous hemianopsia. And homonymous means it's the same side. So homo means same. So here's the vertical meridian, and we've got a right homonymous hemianopsia. And if you have a defect in the tract, it also involves the pupil pathway, so that produces a relative afferent pupillary defect. And if you're involving the geniculate body, it'll cause the nerve to be atrophic because the cell body of that nerve lives here. So if you're in front of the geniculate, but behind the chiasm, you get a homonymous hemianopsia with an RAPD and optic atrophy. And then if you're behind the geniculate body, the patients also get homonymous hemianopsia, but without the RAPD and the optic atrophy. In the geniculate body, the two fields that we're looking for are fields that look like a wedge has been taken out, and those wedge defects look like Pac-Man. So it looks like a homonymous, it's on the same side again, but this time it's not going all the way to the vertical meridian, and it looks like Pac-Man from involvement or sparing of that central wedge to fixation. And so if you have sparing of that wedge, you get this Pac-Man thing, but if you get involvement and sparing of the wedge, then you get this kind of hourglass appearance. So those two are both lateral geniculate body type visual fields because the blood supply either involves or spares that anterior lateral choroidal artery in the geniculate body. Once you're behind the optic tract and the geniculate body, these are called the radiations, and it can be in the temporal lobe or it can be in the parietal lobe. In the temporal lobe, the field defect's going to be denser superiorly. That's called pie in the sky. And if it's the parietal lobe, it's going to be the opposite. It's going to be pie on the floor. And in the occipital lobe, we have macular sparing, where there's sparing of the visual field in the center, but it's still a homonymous hemianopsia. And that's because this occipital lobe has a dual blood supply, the middle and the posterior cerebral artery, that spares the tip. So if you just knew these 5 rules, respect to the vertical meridian, knowing the junctional scotoma and the junctional scotoma traquaire, the chiasmal lesion, which is the bitemporal hemianopsia, the optic tract lesion, the geniculate body, and the radiations and the cortex, you'll know to respect the vertical meridian and find the tumor. And those are the rules you need to know so you don't miss that tumor.